Welcome to Longterm. I'm Ty King, and of course, this is the podcast where we talk about recovery. And recovery comes in all forms, shapes, sizes, and I think it applies to just all human beings in general. I found over the course of the journey of this podcast that we have such a big crossover between all people, no matter what your background is. If you're a military vet, if you're coming out of substance abuse, if you're coming to reassimilate back into society from a prison, or maybe you've grown up in a rural area and now you're coming into a more urban area. Like there are so many different crossovers, and regardless, I think there's something that we need some sort of healing, some sort of recovery from. And we can't do that alone, and it takes effort. And so it's great to have allies that are experienced that can actually help in that area. And like today's guest, I'm really excited to talk to Ariana about what she's done in California. And so she co-founded Bridge, which I'm gonna let her sort of give the description. I would say, just for my once overview of looking into Bridge, and what I'd say, it's a connection, just so I don't use the word bridge again anymore. It's a connection between emergency room services and those who really need it, who are usually uninsured people, and especially, more particularly, uninsured people of color, if that's right. And Ariana, I'll let you go ahead and introduce yourself.
Thank you. Yeah, no, I'm so happy to be here, Ty. So Ariana Campbell, I am a PA and I work in clinically in emergency medicine and now addiction psychiatry. But I've also worked in family practice we call it a bridge clinic, but in like a low barrier clinic for substance use disorder treatment. And I've been a PA for 25 years. So I'll also say that I worked for 17 years really not having a good understanding of addiction, of that we could actually do something for people and in all these general settings. And so I co-founded what at that time was California Bridge back in 2017, 2018, because I was presented some information that we could do something more. And I thought, why didn't I know this before? And so I've been operating from that place of everybody needs to have more information so that when people who are experiencing the effects of drugs, people who have a substance use disorder, want and need treatment, that they are met with open arms and with can have a reasonable expectation of being treated really well in healthcare settings. So I've just been leaning into that over the last 8 years. And so that's the founding of California Bridge, and we became the Bridge Center at the Public Health Institute to expand that nationally, to engage our EMS partners, to work on better access to reproductive care, to also work on screening for, public health screening for, syphilis, HIV, Hep C. So we've seen opportunity to create access to care for people who have often been really excluded from care for various reasons.
Absolutely. And so you founded California Bridge back 8 years ago, but you've been in you got some clinical experience for 24 years.
Yeah, 25 years now I've been working in medicine, and received no training. I mean, I don't know, maybe there was 30 minutes spent on training for addiction when I was, in the late 90s when I was in school, but really didn't have adequate training at that time.
Absolutely. And you got several letters. I always get confused with all the letters that are behind people's titles. Do you mind breaking down MPH and PAC?
Yeah, sure. And I'm also a DMS now. So yeah, so I'm a PAC, so it's called a physician assistant or a physician associate. And so that's my clinical work. So that's where I've been working in family medicine, emergency medicine, addiction medicine now. And then MPH, I actually went back to school as, a working mom. This is 4 years ago. I went to Johns Hopkins and I got my master's in public health because really saw my role of treating individual patients and thought I could bring some of this experience to affect a larger number of people. And I was already kind of doing that at Bridge, but I wanted to get better at that. So I got my master's in public health from Johns Hopkins, and then I just walked for my doctor of medical science. So I got my doctorate very recently from the University of Pacific, and that was in healthcare leadership, really to see how I can affect healthcare systems and exhibit healthy leadership, given the opportunity to try to change medicine to create more opportunities for people to get treatment, to get the care that they need and serve.
You know, emergency care, and why it's so important. I read on your website, for Bridge, about how emergency care is the only health care that is guaranteed to anyone in the U.S., regardless if you've got insurance or if you own the hospital or you have no way of paying. Like, that is the only one guaranteed service that you can get from a hospital, which is incredible. I never even knew that or realized it before. So I guess, like, why is it so critical for what Bridge is doing for emergency care?
Well, we've leaned into this. So when I started, back in the 90s, could have been late 80s, but we there's this Emergency Medical Treatment and Labor Act where we have it's called EMTALA, and we uh, started requiring emergency departments to stabilize emergencies, regardless of ability to pay or insurance or ID. So I say no shirt, no shoes, you get service, right? So it is a guarantee of healthcare. And I do think that there's been this feeling in emergency medicine because it was unfunded. It was like, see everybody who shows up on your door, even if they don't have funding. And so I think there was at that time a tendency to think of this as, hospitals are being forced to see everybody without funding. I would say the moment in my career where my journey in addiction medicine and in emergency medicine became this like sort of blended together is when I said, we can guarantee care to every American, to every person in the United States. That's rad. Like, because just caring for humans. And so leaning into that and then providing the kind of care that people need. So we're also the place where people who, think of like, recently my husband called because he injured his foot. So he tried to make an appointment because he was experiencing a lot of pain. So he called to make an appointment. We have insurance, and his appointment was scheduled in October. Like, does that work? No. But you can get care right now by showing up in the emergency department. And so we wanted to make sure that that's the right kind of care. Like, I, for 17 years, if you came in and you told me you were, you're addicted to opioids, or you were using opioids and you couldn't stop, or opiates or heroin or fentanyl or whatever it was that you were using, I was simply my feeling of actually providing care was, oh, well, here's a list, go find some treatment, pull yourself up by your bootstraps. You might have to hit rock bottom first. All of these things that I learned not through medicine, but, by paying attention, in the community. And that's just not good enough. Like, we actually, under EMTALA, we're required to stabilize emergencies. And so once I just sort of moved substance use disorders into my lane of, oh, not only is this an emergency and there's a moment when somebody's trying to access care, I need a system to support them so that they have it as easy as possible to get that treatment. And this is to serve patients. I can picture the faces of the people who I think I didn't serve well because I handed them a list and they may have come back, they were still using, and I really didn't give them a different pathway out. I really didn't provide them opportunity. And so I think that leaning into that EMTALA, leaning in that emergency departments are required to see everybody, at least stabilize their emergency regardless of insurance status, ID, etc. That made my career, my job so much more satisfying.
For sure. And when you say, emergency room care for people in substance abuse, what typically are they going to the emergency room for?
Well, this is such a good question, Ty, because I would say I wasn't making it safe to tell me about their substance use disorder before. So before I did the work that I'm doing now, which I'll talk a little bit more about, but I would say people were coming in saying, with abdominal pain, with vomiting, diarrhea, if they were like in opioid withdrawal. There was often, people were experiencing pain, so they would come in saying, "My knee hurts, my arm hurts. I have chronic back pain. Back pain has been a big one," and they're experiencing that. So I don't, I'm not saying they're being dishonest, but people are often experiencing, anxiety related to substance use. I just hadn't created a space necessarily where they were talking to me about, like, they knew the reason behind their symptoms, but they didn't necessarily feel safe talking to me about it. I also see a lot of people with like abscesses, pneumonia, and then I see more, people are experiencing other crises, where they're in distress and they may be septic, so they may have like a blood infection, maybe because they were avoiding medical care because they didn't want to be, identified as somebody who uses drugs.
Yeah, that makes a lot of sense. And I know medical services are used in a broad range, to treat, people that need recovery. And so they're not, usually they're not in the recovery process yet. Usually it's because a medical issue has arisen and like this is a symptom of them using, like you were talking about, if they're having withdrawals. Here in Arkansas, like it's not uncommon that people drive around. Like I've got one in my car right now, a Narcan kit. You know, what I mean, in case we see somebody who's overdosed, we've been trained to be able to administer that. And I had the opportunity yesterday to go visit one of the research groups that does clinical trials on medicine to help people curb their addiction in their bodies. And so there's so many different angles to come at it, and I don't know how many people realize that there are actual medical medical services associated. It's not like what we talked about before we started recording here. My initial thoughts, years ago, before even learning about any of this, was that, you have the intervention, then you go to rehab, and then after rehab, you should be good. You get out, you're clean, and like, you have a new outlook on life. But that's not the reality for a lot of people because it is having a physical effect on your body. And then I can, either you're ignoring existing medical issues or, like we were talking about the emergency room, services, and I was thinking, good 2 or 3 years ago, I was having like a very severe abdominal pain, and I was just kind of power through it. And I was like, oh man, just must have just eaten something that was bad, or like I'm just having muscle contractions because maybe I did too much working out or something. I don't know. And eventually went to the emergency room, and it turned out my appendix was about to burst, and so I had an appendectomy, in right there in the emergency room. But I wouldn't have if I had called ahead and be like, hey, I need to set up an appointment. Like it was probably life-saving that I went to the emergency room and they were able to operate on me so quickly. But I think about in people in addiction, maybe they just keep, powering through it, or they ignore those problems and be like, oh, I don't need to go to the hospital. All I need to do is get me another, whatever their fix is at the point, which is, life-threatening, of course. And so, um, yeah, I guess so for the average person that's not really familiar with that, like what are some things that the hospitals do for people who are, in their substance abuse issues? I know we talked about, it maybe withdrawals and I don't know. Do you have an example of like what those withdrawals look like for people?
Yeah, so opioid withdrawal. So, I mean, honestly, people come in for all sorts of things. People are experiencing mental health crises. Sometimes people come in under arrest. We're like this, this is where people end up in different, different parts because I mean, emergency departments I think are beautiful. Like people have other feelings about that when I say emergency departments are beautiful, but like you were describing appendicitis, so you come in with abdominal pain. We can get labs right away. We can get imaging, so we can get like a CT scan, or we can call the surgeon. Then we admit you, and we get it all done all in one spot, right? You didn't make an appointment for 3 days from now. You didn't have to go to all these different spots. So I like love practicing there because I can get people often answers of sometimes what it is, sometimes what it's not. But so it's just like taking that thinking and applying it to somebody who comes in with, let's say somebody comes in withdrawal. So my very first patient came in and was experiencing opioid withdrawal. She was pregnant. She's like, I'm done using, at that time it was heroin, and I need help. And I need it now because I'm pregnant and I can't get appointments anywhere and there's all these complications. And so she was in withdrawal. And what withdrawal from opioids looks like, I mean, everybody has, I actually ask my patients what happens when you're in withdrawal. But what we typically see, it's which wasn't trained in when I first went to school, right, as a PA. But people get goosebumps, people, they get diarrhea, vomiting, abdominal cramping. So, like I said, some people come in with abdominal pain because they're in withdrawal. They get sweaty and they yawn a lot. I didn't know people yawned a lot as part of opioid withdrawal. That's actually for me when somebody's yawning a lot, I know that they're in withdrawal and would, that there's certain medications that would help them. And their pupils, if they're using opioids, so pupils are usually constricted when they're in withdrawal. They dilate and then they get like a runny nose and watery eyes. So those are the things I look for. And it's interesting because just having that skill, it's like I say, as somebody who's practices medicine, having more tools in your tool belt's a good thing. So sometimes I do get people who are afraid to disclose that they have that they're withdrawing from opioids because they're afraid I might treat them poorly. Then if I can identify it and I just ask the right questions, then often because I pair it with, hey, I can help you out with this. So if somebody comes in, but my back to my first patient who was pregnant, she came in and saying, I'm in opioid withdrawal and want help. It's like, oh wow, she told me exactly what she wants and needs. All I need to do is do the right thing for her. So yeah. So I'd say people come in for different reasons, but if we are able to identify withdrawal or just able to talk to somebody about their use disorder, then we can invite people in to treatment and resources, which is really important.
And good for her to tell you outright. And like, I'm sure that helps a lot whenever somebody's for outright. Hey, this is what the problem is. Okay, great. But she probably knew the reality of like how much pressure there was on, or like how important it was to get to service as soon as possible, especially with a child.
Yeah, and it was just my job to be prepared for her, right? So for 17 years, I wasn't prepared. Somebody come in and I would say, wow, here's some medication maybe for nausea. I was just like sort of treating some of the symptoms that she was experiencing. And I'd give her a list and say, go find treatment. And one of the inspirations to me developing what I did in a rural community at the first hospital I ever implemented something in was, it's a small community. So you actually hear from people who maybe it didn't go well. And I gave somebody that I call it the list. Here's where you can go get treatment. And they were like, hey, did you know that half those places are for pregnant women? And I gave it to him, to a man. And he said, and did you know that most of them require a lot of money up front? I don't have money. I've been using, yeah, like I don't have any money. And then there's these waiting lists of like 6 months or 9 months. They told me just to continue to use. So, I was embarrassed. I thought, "I can't believe that that was my medical recommendation." And so I changed. So, changed my practice based on, what I knew, and there's already a lot of information out there about what really does work for people, and it's different for all people. It's giving people choice. It's giving people, like, good information and then letting them pick their path. That's been really important.
Yeah, that's amazing. And you yourself learning along the way of what works best. And yeah, it's incredible. I think that's the best way path forward is learning what works and what doesn't work. There are lots of organizations that are looking at, okay, data driven. What are what results are coming out of which programs and services that we're using that are being effective, and we can just look at the data and show that, and then put together, make changes here and there because changes always need to be made when you make a program, especially concerning, something like substance abuse. It's rarely perfect. I've never heard of any, program being perfect right off the bat, right? So it's always you have to make changes and alterations.
Yeah, and I think, I bring a unique perspective here only because I've practiced medicine in various care settings for a while. I feel like I have this insider knowledge of how it all works, right? And I always say everybody needs a friend in medicine. I can't tell you like uh, I people text me pictures of a rash all the time. Like, hey, what do you think this is? Or here's a cut. Do I need to go to the ER? Or my son just fell and hurt his wrist. Can I send you a picture of it? Tell me what you think. Do I need to go to the ER? But I think everybody needs a friend in medicine. And so I do think in some way, shape, or form, having an emergency department that's friendly and that is going to give you really good advice and give you reasonable options is, I'm always happy to be somebody's friend in medicine. So, and I see that when I meet people in the ER.
Seeing how important emergency care is and how, like you said, that's the only guaranteed sort of healthcare that is available to every US citizen. You know how important it is. So obviously you've seen, as you put it, there was a need to bridge the gap, which is why it's called bridge. No, it's pretty straightforward there. To between emergency health care and community health. And so what does that mean? What was the gap that was happening, and what does bridge solve?
Well, thank you. That's a good question. So I can't take credit. Like I did build a program in my emergency department, but I didn't know it was supposed to be hard. I had somebody from a community health center come in, and my version of the story is different from there. So I do definitely want to acknowledge that. But they said, I was in leadership, right? They said, go to this meeting and hear this person out. I had no idea what it was about. So I go to this meeting, and there's this person in the community. It's a physician who is prescribing medication for opioid use disorder. And so he said, hey, I'm really hoping you can help us out by starting people in the ER on medication. And I said, well, isn't that illegal? Isn't that substituting one opioid for another? I said all of these things because as a healthcare provider, I didn't have good information. And luckily, they helped give me some information and resources so I could educate myself. And I realized that I was missing the mark, that we should be initiating spot for people with opioid use disorder because they can come in 24/7. If they decide they want treatment at 2 a.m., we're there as long as we're set up for it, right? So we get the right medications that we can give. We we work with our community partners to make it a good experience for people. We hold ourselves accountable to it, and we try to listen to people in our community about how it's going, and then every time somebody tells us that something didn't go wrong or didn't go well, we try to fix it. We try to like think of every barrier that person has to treatment and try to fix it. So that's how we started out. And then so I started that program with this community partner, and we were just trying to do them a solid by because they said they were the people who were like having to book people in 1 or 2 months, and that they realized that wasn't acceptable. So we partnered with them to care for our community. And then what I didn't realize was going to make an impact on my career is I have a sister who actually died from the effects of drugs. And I thought, like, what would it take? What would be needed so that people felt more comfortable talking to me? Because it felt awkward at first, actually, when I was trying to talk to people about drugs. But there can be like kind of a power dynamic there, because I'm a prescriber and they don't want this in their medical record. So I thought, how can we become an inviting place for people? And so we developed this job called, it's called a navigator. They've been called substance use navigators or SUN or a behavioral health navigator. Because I thought, my sister was going to the emergency department a lot before she died. And I thought, what if there was somebody there who was just cooler than me? Who was just like, who would actually talk to her in a way that maybe she could have like seen a different path out. And what if she paired that with medical care and then the providers were understanding and not just understanding, but also offered treatment? And what if there was a really easy way for her to get that treatment? And so we came up with navigators, and I really did think of my sister and who would she have talked to? And now we have, gosh, a whole workforce of navigators in California because that's how we envisioned doing this in an emergency department. And and we put signage up. I wear a button. We advertise this, and we really have intent on making it easier for people to talk to us. And I think that that's like a big thing, with like changing sort of emergency medicine and how we can affect care. Like we've provided access to hundreds of thousands of people in California now, who didn't have access to care before, and in every community. We've worked in almost every county in California. 85% of hospitals in California now have a bridge program, and it's been 100% informed by people who use drugs, by people who have access care. We really try to acknowledge some of the deficiency we've had, and that changes communities. My navigator goes out and talks to our, maternal, we have different like resources in our community. For us, we have a lot of issues with pregnant women getting care. So we go talk to them. We do presentations for them. We look at all the resources in our community, and then my navigator is an expert in pairing those resources to the people who come in. So could you imagine, like, so the way I think of it is, think of if your family member called you, and it's, oh, by the way, because I am that family member, it's always on Friday night, and says, I'm ready for treatment. I need treatment now. What do you do? You know? And a lot of people Google it, and there's, I think, a lot of, just information that could be misleading or could cost a lot of money or present barriers to people. But what if you thought, if you knew you could go to an emergency department, and what if you knew that there was a really cool person there who is going to advocate for you, treat you well, and then connect you with care? Like, how cool would that be? Well, let's say you didn't intend to go to the emergency department, but you had to go there because, like, what you were talking about, maybe you had an abscess, maybe you were really sick and you were going to be hospitalized. But you need to use drugs, right? That's what you do. But what if there's somebody there who is like advocating for you, getting you the help you need, and then connecting you to the community resources when you leave? Like, I think that's what any of us would want for any of our family members.
And emergency departments being, sort of a forgotten or underused partner in overdoses, especially. In your experience, I definitely want to, a couple of different things I wanted to ask you, but how do you feel, mentioned, Narcan, which is like, there's a big application for Narcan here in the South. Like the southern states have really taken to it, and they're like, I mean, it's like, yeah, I don't want to put like it's like candy. But I mean, like you go through a training which is like maybe 5 to 10 minutes, and they show you how to use it exactly, how to look for signs that somebody has overdosed and what you need to do. And then, you carry the Narcan with you so that you can, save somebody's life. But that's not the final step. Of course, they go to the emergency room after that. It's like, do this and call a 911 to get them in there. How do you feel as an emergency department, provider, about, I guess so many citizens having, I guess, like Narcan to where they can administer this? Is that a good thing? Is it a bad thing? Is it a medium we haven't seen yet?
Oh, absolutely life-saving. So, we've given, I think we're almost at 1 million doses of naloxone given out from emergency departments in California because we're so but it's not enough. So, it's not enough just in naloxone. Like, we wanna saturate communities with naloxone because, yeah, if this was my sister and my sister was using opioids and was at risk of overdose, I would want her to live. People don't recover unless they're alive, right? So, that's first and foremost. It's also not enough. So, though I am the most passionate advocate of naloxone, I even have like a naloxone trainer with like a nose on it where I'm constantly showing people how to administer that. I think it's about 85% of people who died from an overdose died alone. You don't administer Narcan to yourself. So it's also super important to offer treatment. So we offer medications to treat opioid use disorder. We offer buprenorphine is the one that you hear about. Well, and methadone. It's whatever path people want to take, but we offer those medications because you think of that person who died alone, their risk of dying is cut in half if they are started on one of those medications. So cut in half. So, I mean, I'm always looking at ways to, live a longer life or more healthy life, for my family, my friends, right? And yet we often overlook at the actual medications to treat opioid use disorder, or for that matter, alcohol use disorder, which is like the number one killer, right? We can do so much in emergency departments to treat people with alcohol use disorder, opioid use disorder, and it's all about having that tool in your tool belt and then offering it. Like when somebody comes in for a trauma, I've had people come in because they were, using fentanyl, got in a car wreck, or something happened, and they come in. Man, so many people, in fact, when 85% of our patients who were offered treatment from a substance use navigator in an emergency department setting, they accepted treatment. They accepted help. Like, people often find like, well, that didn't go well. Maybe I should do something, right? And so, people accept treatment. People want treatment when it's offered in the right way. We also are treating a ton of people with alcohol use disorder. People crash cars, people fall who are drinking alcohol. And what if during that time you're like, hey, do you want to cut back? And not saying, people, I always say you don't have to decide to like enter residential treatment or anything. I can just give you medication that may be able to reduce how much you're drinking, so it could reduce your heavy drinking days and give you an opportunity to maybe think about what you want to do. And there's all these different resources and how to do that. So it's 95% of people in the United States with a substance use disorder are not getting any treatment at all. So it really is an opportunity for us to step back and think about how we offer treatment and change it so that people may want to engage in it. Because, if there was any other medical problem, if, you know, 95% of people with heart disease weren't getting any treatment, we would all be up in arms, right? Say, oh my gosh. Yet we have this really fatal condition. We have this fatal issue with fentanyl. I mean, fentanyl use is very dicey, right? And offering treatment at every opportunity, offering a path out, offering safety, offering life. Hey, we want you to survive. We want you to live a good life. We want you to meet your own goals. How can I help you meet your own goals? And 85% of the time, people are accepting treatment. So.
And are there any additional complications? Because I know that you've got experience as being a rural, emergency department, and so we know all about rural areas in in these southern flyover states, right? There's like the populated cities are few and far between, and so oftentimes that creates sort of another challenge for treating, especially if somebody has overdosed or if they're at the risk of serious life, life threatening, something because of their use of substance abuse. Because there's many, many miles to drive to even get to the emergency room. Has that provided any sort of challenges for you as well?
Yeah, it's really interesting. People forget about our rural communities. Of course, it's the top of my mind. It's funny. There's a community like you don't know what's there unless you look. I was looking at my own county, and I'm always trying to just like, are we doing a good job? Is it going well? Is this helping? And we saw that our highest overdoses were in the super rural part. So like as the crow flies, it's probably only 8-10 miles from my house right now, but it takes about 35 minutes to get there, windy mountain road, and highest overdoses in our county in this small and beautiful community. So I went to work up there so that there's this little clinic that's in like an abandoned bank. It's like wherever we can see people. And they started doing some family practice there years ago. And they weren't treating addiction though, right? And there was this big need there. So what people would say, well, we could do telemedicine. A lot of my patients up there don't have Wi-Fi. In fact, many of them are intentionally sort of off the grid, right? Um, so it's not like the public library has Wi-Fi, but that means somebody has to drive there, and so many people live so far from that. People, there's no access to, there's no pharmacy up there. So even to get medications, people have to travel. So we just had to think of it from our patient's point of view. So I went up there. I worked with these amazing nurse practitioners who were doing family practice there. I taught them really how to do this, and a lot of it's just how to engage people in care, how to treat people. And then we started doing a lot of injectable medications because it was just easier for people. Um, so we just listened to our patients, and then we developed a relationship with a pharmacy who could deliver medications up there. We got naloxone, like to your point, we got naloxone easy access in our clinic. In fact, we were having a staff meeting, and somebody, comes out of the fog, like on a bike, knocks on the door and needed naloxone, and we were able to just like hand it to them because they knew that we had it. And I am sure that they went and saved somebody's life. So it was just trying to make it being prepared as a rural setting by thinking of the journey of the person who's living in a really rural setting and then listening to people. And, it's funny because like a lot of sort of people who are building programs will say, well, we have transportation, we have like a van. But the reality is there's snow, there's flooding, there's like things that happen in rural communities. And like Bob, the guy who drives a van, doesn't show up sometimes, right? So it's actually being very understanding. And then, like, if my patient didn't show up to an appointment, let's say, it's not just, well, they didn't show up. Now they're going to be in trouble. I just call them. I'd say, hey, you had an appointment today, but things happen. What can I do to help you? and most of them would answer the phone. And they just said, "Oh, my ride fell through, my this," it's acknowledging that and literally meeting people where they're at. And then we even had some home visits. We had people who'd go to people's homes who really had no access. So I think it's just like really coming up with a spectrum of services that matches your community needs.
You mentioned earlier in the show, and so now that we've sort of covered the ground on like why emergency work is important, what Bridge does, and like some of the challenges that you've reached and what you're doing. So be converting it from California Bridge to Bridge, which is a program inside of Public Health Institute now. Can you talk a little bit more about that and how that happened?
Yeah, we're set on changing medicine. Like we want this to be in every community in the United States. And a lot of it was, with some humility, right? We did this in California. I can't say that word in many places. California, sometimes it's not met with as much, friendliness. But so we actually set out to see if what we learned here resonated. Does it work in other places? And one of our first places we did this was in Louisiana. And so we went into a small parish in Louisiana and we just looked at what they had going, and they had a lot of amazing things going on. But there was little things that made a really big difference. Like they had navigators, but their navigators weren't in the ER. The navigators were sending people to non-medication based treatment. They didn't have naloxone that was easy to access. So we just helped them figure out how they can change this in their own community. And they saw a sustained massive decrease in overdose deaths in that one parish, even while the rest of the state saw an increase in overdose deaths. So it's these like community people we were able to help them build their system. And so it's like it's lifting up community leaders. In Arkansas, we worked in Arkansas with Jake Mum. So if you haven't met him, you should have him on your show. He's a super cool human being, emergency department physician, who also was doing some work in Texas, and then he saw in his community in Arkansas that there was this need for treatment. So he started up a clinic like in a van because he had to get to people in rural parts of Arkansas. And this is just somebody who's like intentionally looking at barriers for people in Arkansas in rural places, and then how to stand up a program. So we worked in Arkansas and helped them connect with other, resources from the emergency department. Where can people go? Where can they go rapidly? What does that look like? Does their insurance, what does, is Medicaid, like how's it paid for? So like all of these things were really important. And so we've worked now in more than 20 states, and we just do this really quickly because I started my program in my ER in 6 weeks. So that's kind of the same ethos we follow. This doesn't have to be a several year project. You can just get started now. And so that's what we do to help people, local leaders, start their own program, because often people just need to know where to start. Like, okay, this sounds great. What's number one? What do I do? And so we just help them. We help them get going. And then now we have this network of incredible leaders across the United States who are just doing such important work and trying to stand this up.
For over 20 states that you're working with now, is the goal to be within all 50 states?
Oh, yeah. And we've worked with people in all 50 states. We've just done a little deeper work with champions in 20 states, and we're doing that through the Opioid Response Network. So we work with a grant funded organization who is funding us to go in and just help people get started. And then we always stay connected to them. So we really try to, then we connect them to each other. So we're trying to build a movement. Like the goal is to cut overdose deaths in half in a really short period of time, in 5 years. And the only way to do that is to get this in every community. And the only way to get this in every community is to have local leaders. So it's just trying to build that movement and really naming that this is something that we should have been doing all along for every substance use disorder. And that starting here can create access to care for loved ones. Almost half of Americans know somebody who died from an overdose. That's unacceptable. Like we really need a better system of care across the United States where I always say, like, if you saw the hospital sign on the freeway, right? Hospitals are infrastructure. So you see that H sign. That's what it looks like in many states, where if you saw that, you knew that if you were in crisis, if you needed treatment for withdrawal, if you needed care for anything, that you would be given this, you'd be offered evidence-based medications. You'd be offered, a path forward that would resonate with you, that would work. That's what our dream is in every community in the United States.
Would you happen to know how many overdose deaths happened in the past year or so? I'll just a quick search, and CDC says around 80,000, 391 last year, which was a decrease of 26 percent the last year.
Yeah, we are seeing significant decreases in overdose deaths across the country right now. And I'm telling you, it's related to the work of a lot of heroes across the country who are getting naloxone out there, who are getting medications out there, who are trying to create access to care. It's still not enough. We still had more than 80,000 people die last year. So, people we love are dying. A friend of mine, who's doing some really important work in North Carolina, his name is Nab Dasgupta. He'd be another person to have on here. He's a fascinating human being.
Okay. I'm making a list as you're talking. I'm like, this person.
Yeah, he's a data scientist and he's really digging into the decrease in overdose deaths. What do we think is working? What's not working? And when we saw like when COVID came along, every community had this like emergency action plan. But we have seen more than 1 million people die from overdoses over the last, 20, 25 years. Where is our emergency action plan for fentanyl, for alcohol? And so we're really trying to move with urgency so that everybody's family member and friend has a reasonable course to seek treatment. And NAB has done a really good job of looking into the data that's out there. You already talked about like sort of, looking at this from a data-driven approach. And he's sort of this ultimate person who's really looking at that data, digging into it to see what's working and what's not so we can make changes.
And we know you can affect people's lives, in ways that are like unquantifiable in that way, of course. You know what I mean? You can, when you help somebody that has come in for an overdose, well, their somebody's daughter, son, brother, sister, father, mother, whatever. But like, so those people you're also affecting. But yes, there are a lot of yeah, especially politicians, right? So legislation boards that are put together that are looking for data driven solutions to recovery or substance abuse issues or um overdoses, opioid, especially if the lawsuits that were won over the past few years over opioid prescriptions, and it's been distributed across the U.S. Am I right now? Each state got a cut of that, but there's like over $3 million that was given to Arkansas in the past couple of years that has to be distributed by a separate nonprofit organization that was put together under the state called the Opioid Recovery Partnership. And so they decide, well, you get this amount of money for housing these people and doing prevention. You get this amount for doing this. But there's, like you were saying, there's the emergency. We're not figuring that in. You know what I mean? Because, okay, great that you're doing prevention, which is you're educating people on what can happen. You're providing recovery for the people that choose to do recovery. But even the people that do choose recovery, some of them relapse, and there are a lot of people that just don't go into recovery, and like they have to have that life-threatening, eye-opening sort of experience before it even causes them to want to be like, okay, I can't do this anymore, and that's usually a trip to the emergency room, um, because of something like that. And so having an action plan to how do we treat those people. I've heard, I'll get your experienced opinion on this. For a temporary time, they tried a program in a city here called Pine Bluff, where a nonprofit organization full of peer recovery specialists were partnered with the police department. And so if somebody called in, if 911 was called because someone had, overdosed, or yeah, if they yeah, that's what it was. If they were overdosed, then of course emergency comes out, what I mean, the ambulance comes out, picks them up, and if they're in critical state or bad enough state where they're not conscious, then of course they're transferred to the hospital, without talking to anyone. But if they're able to speak, then one of the peer recovery specialists comes out, speaks to the person that has overdosed, and rides with them in the back of the ambulance all the way to the hospital, stays with them, and then talks them through it, and basically tries to talk them into recovery. And also working with the police, tries to define where did you get the substances that you took in the first place, so they could track that down and stop it from where it was coming from. Um, and so that was one solution that they tried, and it just sort of faded away. It lasted a few months, but then didn't really go anywhere. I don't know. What would your opinion be on something like that?
Got to make it easy. And I mean, with police involvement, it would makes me think that people may not be disclosing their use. So, I mean, that's just my initial reaction. But what I would say is making it easy has been a big difference. So, if you look at we first of all, when you mention emergency departments, sort of in crisis response, emergency departments are overdose receiving centers. How could you exclude emergency departments from your plan if they're the overdose receiving centers, right? And that's been kind of our point all along. Like, why are we not initiating more opportunity in emergency departments? And it works when we do this. So when you make it easy, first of all, like little things, like we actually wouldn't want somebody to have to wait for transport for somebody to show up. We want them to receive standard of care treatment, which is immediate transport if that's what's indicated. So we have at the overdose receiving centers, which are our emergency departments, we have navigators there. We have systems of care to invite people into treatment. And we have physicians, PAs, nurse practitioners who can prescribe medications to alleviate withdrawal. So if somebody was reversed on naloxone, we could actually give them medication afterwards that would then take them out of the withdrawal that the naloxone caused and protect them from death, would reduce their risk of death by half. So and then connect people to ongoing care. So we need to make sure our overdose receiving centers, aka our emergency departments and hospitals, are equipped to do that. We just published, not we, some really amazing researchers published in JAMA about our work in California in the Journal of the American Medical Association, and they showed that this is just generalist emergency department people like me, right? Who or not like me, people who just started doing this, who give a person medication. They give them this medication called buprenorphine, and then they looked at what happens in 6 months. 6 months is like a long time, right? For anything, for anybody to be in any treatment for a chronic disease. And they found that there was actually a really good number of people, 1 in 9, who were still in continuous treatment. Like, they got started in the ER, and then they continued treatment, never had a disruption in treatment for 6 months. Like, that's amazing. And 1 in 3 were still in treatment even if it was, like, interrupted for a period of time. Could you imagine, like, when I mentioned that 95% of people aren't accessing treatment, what if we had that all over the place? Like, inviting more people into treatment, this treatment that can cut their risk of dying in half. We could when we've said we wanna cut overdose deaths in half, that's what it takes. And so when you mention your system, I love peers. My navigator in my hospital, the only navigators I've hired have lived history. It's been an important thing to me, and that's its own talk because, getting people with lived history who have well-paying jobs, benefits, they're not volunteers. This is their career, this is their job, and they'll talk about their lived history and are connecting with people, and they're part of that. It's kind of like having your trauma team. My navigator is part of our overdose receiving team, and so we're set up to meet the needs of people who use drugs in a way that invites people in. So I think and then we've kept it simple because from the start, I think I practice in the emergency department, so I also know that we just have to make it really easy. So our navigator has an access to is watching our board. We all have this electronic board. They're watching the board to see if somebody hasn't disclosed it, but maybe they see that maybe this is a possibility. They'll just go down and talk to somebody and say, "Hey, how's it going?" They won't even say they're a substance use navigator, but I just, see you're waiting. I'd love to chat with you. And so it's really creating opportunities for access and keeping it simple, and then honoring our peers by putting them in positions, like paid positions, for example, in hospitals, emergency departments, clinics. We have every one of our clinics now has a navigator, people with lived history who are working in all of these medical settings. So we also have a whole job force now that is served by people with a history of substance use. So I think it's really important.
Something I wouldn't expect, but yeah, that's amazing that you're implementing that. Yeah, I'm glad you brought up the Bipinephrine because I had questions about that because this one I've not really heard about before. I did. I was able to see that. Let's see, Bridge across California since it was formed. You've been able to prescribe or administer Bipinephrine to over 100,000 patients just in California. So what is Bipinephrine and what does it do for the body?
Oh, so buprenorphine is a medication that is in the opioid category, but it's just a very unique one. So it doesn't give you all the, sort of the high and it doesn't make you stop breathing, most importantly, right? So people, when they take buprenorphine, it treats their craving and it treats their withdrawal like very quickly. So, and then they can feel normal. So this is somebody with an opioid use disorder. So whereas when they're on like, when they're taking fentanyl or heroin or oxy or whatever, they're way up here and, this opioid, when they're on buprenorphine, they're able just to kind of feel normal and it's long acting. So it's just steady for them, but it protects them from overdose. So this is really important. It blocks other opioids, the ones that can make you stop breathing. So it can make it so you don't crave these these agonists or these opioids that can make you stop breathing. So it blocks them and it keeps you from craving them. So people can just go on and move on with their life. Methadone works too, but methadone is one of those, one of those, we call them full agonist, but, and methadone works for a lot of people. There's just a lot of regulations, and particularly in rural settings, it can be really hard to access. So we've leaned a lot into buprenorphine because honestly, I have patients where I prescribe it. They're given a prescription once a month or once every 3 months when they've been in treatment for a while. There's even injections of it, so people can get a once a month injection, which I had mentioned before at the clinic I was working at. That was a real game changer for a lot of people who had transportation issues, but they could come to our clinic once a month and get an injection. So it's just having options for people and making it so it's like, what if you had opioid use disorder? What would you want to do? And I think you'd want choice. So that I'd want to make an informed decision based on the choices given. So it's having options, but also really knowing what's the thing that makes it so I can, live my best life and how do I fit that into my life? So that's what we're trying to do, and that's why we've leaned into those medications because they keep people from dying.
Okay, yeah. Thanks for educating me. Not and I knew I was butchering the pronunciation of that. I was like, I'll let her pronounce it. Yeah. I would just call it poop. Uh,
Terrible name for a medication. I mean, people know it as Suboxone, which is easier to say, but there's a lot of Suboxone is like it's buprenorphine because there's a lot of different forms of it that are not Suboxone. So that's why I use the really awkward name with the P before the R.
oh, yeah, thank you so much for your sharing and for educating, for taking time to talk about what it is that you're doing, and of course what you've done with Bridge. But also, as emergency services, you know, uh, service, that you are, because you're treating clients, but have been through. See, you saw an issue, you saw a problem, you saw something that needed to be solved, and came up with a solution, and you're continually learning and improving that option and making it more widely available across the U.S., which is incredible. And so, yeah, thank you for what you do, for one, and for sharing your time and for educating us on that.
Yeah, thank you. Yeah, our dream is that there's like one phone number somebody can call, any family, friend, person who wants, treatment could call a number and just be connected to medications, to treatment that works for them and fits into their life. So that's the dream. We're going to keep pushing for it, Ty. Thank you for having me.
Yeah, for sure. Um, if people want to find out more about Bridge, and what you're doing for emergency services, where could they go to do that?
Yeah, bridgetotreatment.org. So you just spell it out, bridgetotreatment.org or cabridge.org. Go to our website. We have a ton of resources for people. We're trying to make it so nobody has to reinvent the wheel. You could if you're a medical provider, if you're a nurse, if you're at a clinic, or if you just want to provide information to your medical provider on what this can look like, or your family to support your journey. There's just a lot of good resources on there. So we've been pretty obsessed with creating resources for people. So yeah, or if you just want to reach out to us, we do have a contact us, button on there, and would love to hear from people too.
One last question. So I always ask this of people, but I'm pretty sure I know your answer because that's what we've been talking about the entire time. But I usually ask people at the end of the interviews, with all of your experience and, of course, personally, but also professionally, and then seeing the need and coming up with a solution. What is a long-term solution that you recommend? I guess in this case would be for emergency services. Maybe they haven't been tapped into Bridge yet, or yeah, maybe they're not aware of like what's available to them. What is a long-term solution for that?
It's really developing a whole system of care that makes sense. So it's integrating care. It's making it easy for people to access it where there's common understanding of what that can look like a 988 that connects people to care, and it's family members knowing to support that. It's people knowing that that's available. So I liken it to our trauma system. If you experience a trauma, you could, you that if you went to the emergency department, you should get a certain level of care. Not We all know there's spectrum, but a reasonable amount within a spectrum of care. And that's the dream, is really for substance use disorders, that it's easy for people to access treatment, and that we provide opportunities for that at every touch point, every place that people who use drugs or people who use alcohol and are suffering, where they access care or access any resources.
Perfect. Absolutely. Well, thank you again. And thank you for listening. If you are on one of the audio platforms, you can find the video version on YouTube, and vice versa. If you're watching this video on YouTube, you can find us on all of the major podcasting platforms, from Apple to Amazon to iHeart, wherever you prefer to listen to your podcast. And if you listen to this episode and you heard something that Ariana was talking about, especially with the emergency care and the complications in rural areas. I mean, all the different areas that we've covered, and the medical options that are available for people that need recovery or overdose. Share this episode with someone that needs to hear that. If you know somebody that needs to hear the message, if you heard somebody that could benefit and learn from this, share this episode. That's the quickest way that you can help us grow, but also to send out this message to the people that need to hear it, so that we can make real positive impacts in the world. We love the shares, we love the subscribes, and the comments and likes and all of that. Those are great, and so it helps the channel grow. But the number one thing that you could do to help is to share messages, so that Ariana's message can reach more people, and make more awareness and more education, for the common people that would need to hear that, of course. And so, thank you again for joining us for this episode, and we look forward to seeing you in the next one.